Hello class, welcome to our very last online lecture. Today we will be talking about Chapter 69, Care of Patients with Urinary Problems. Let's talk about our learning outcomes first. We're going to teach our patients about pelvic floor exercises. We'll coordinate care to prevent UTIs. We'll talk about different types of incontinence, and we'll also differentiate between cystitis and urethritis. We'll describe risk factors contributing to UTIs, and we'll also talk about ways to prevent UTIs. We'll verbalize various aspects of bladder training and habit training. We'll learn how to implement strategies to minimize catheter-related infections. We'll be able to describe common examples of drug therapy for UTIs. We'll teach clients about the proper management techniques for urinary incontinence and renal calculi. Here are the disorders that we'll be discussing today. They are broken into two sections. The first are infectious disorders, and the second are non-infectious disorders. Let's do a little introduction first. The urinary system consists of the kidneys, ureters, bladder, and urethra. When problems in the urinary system interfere with the mechanics of moving urine out of the body, problems happen. The problems include less urine. It also includes problems with homeostasis. There are different changes with the fluids, electrolytes, waste, and blood pressure. Urinary problems affect the storage or elimination of the urine. If there's a problem in the bladder, it's a storage problem. If there's a problem in one of the ureters or the urethra, there's an elimination problem. Both acute and chronic urinary problems are common and costly. Now, can you think of why? Why are these problems common and why are they costly? For nurses, we need to intervene. With our patients, we need to look for ways to prevent urinary problems. We have to detect a problem if we see one, and we have to learn how to manage urological disorders. UTIs are the most common healthcare acquired infection. UTIs are described by their location in the tract. The infections can happen in the urethra, in the bladder, or in the prostate gland, or in the kidney itself. The respective names are urethritis, cystitis, prostatitis, and lastly, acute pyelonephritis. Now, why do we need to know where the infection is? Well, the site of infection is important to know because site, along with the specific type of bacteria present, determines the treatment. So the doctor will want to know where the infection is and what type of bacteria is there. Let's talk about ways to prevent a UTI. Throughout the different chapters for renal, there are different amounts of liquid recommended. It goes from 1.5 to 2 to 3 liters to more. So let's just stick with our textbook answer together being encouraging our patients to have 3 liters or more fluids daily unless contraindicated. So we want to make sure that our clients and ourselves have sufficient sleep, rest, and nutrition. Ladies, remember to clean from the front to the back, wear loose-fitting cotton underpants, wash before whoopee, and call your healthcare provider if there's burning when urinating or you notice an increased frequency. Also remember to visit the restroom regularly. And there's more on chart 69 too if you are interested. Let's talk about some risk factors that contribute to getting a UTI. Incomplete bladder emptying. When that happens, the bladder holds more urine than it should, and it becomes a breeding ground for bacteria. The same goes for when large stones obstruct the urine flow. It stores more urine in the bladder than it's supposed to for longer periods of time than it's supposed to. Another problem is if the urine goes back from the bladder to the kidneys and ureters, we never want a backflow. This reminds me of Foley catheters. Make sure that they are below the client. Now, when there's too much glucose in the urine, bacteria love that. And when the urine is alkalotic, it can contribute to getting a UTI. Women are at a greater risk than men because of our anatomy. Advancing age and disease. If a client is already immunocompromised, then it may increase their risk of getting a UTI. Their body just might not be able to fight it as well as other people. Also, for irritation of perineum and urethra during intercourse, that can be a problem because the bacteria from the outside is pushed into the inside and can cause problems. Also, if there was a recent use of antibiotics, that's a risk factor for contributing to UTI. All right, the left comic strip has the devil saying, "This is really embarrassing, but it burns when I go." And on the right side, the poor bear is saying, "I seem to be trading hibernation for urination." We're going to be talking about two infectious disorders, cystitis and urethritis. Earlier, we talked about UTIs and how the bacteria can land anywhere in the urinary tract. We're going to focus on two areas, the bladder and the urethra. Cystitis is the medical term for inflammation of the bladder. Most of the time, the inflammation is caused by a bacterial infection, and it's called a urinary tract infection. Urethritis is a condition in which the urethra, or the tube that carries urine from the bladder to outside the body, becomes inflamed and irritated. Urethritis typically causes pain while urinating and an increased urge to urinate. So remember, pain and increased urge to urinate. The primary cause of urethritis is usually infection by bacteria. Let's first look at cystitis. It's the inflammation of the bladder. It's most commonly caused by bacteria moving up the urinary tract from external urethra to the bladder because of irritation, trauma, or catheterization. So we never want to keep a catheter in longer than we really need to. Catheters are a high risk factor in developing nosocomial cystitis. Go ahead and read through chart 69.1. Let's talk about some signs and symptoms of cystitis. There's a frequent urge to urinate. There's a sense of urgency. There's dysuria, pain when urinating. There's hesitancy or difficulty in initiating urine stream. There may be some low back pain, some nocturia, some incontinence. Let's talk about cystitis treatment. Take a look at chart 69.4 and go ahead and fill out your chart so you can learn a little bit about the drugs that are used to treat cystitis. Nutrition-wise, we want to make sure our clients eat from all the food groups. Also, more calories may be needed due to increased metabolism because of the infection. The client needs to hydrate. The sitz bath is a comfort measure that you may want to try. If worse comes to worse, surgery may be needed. Some examples would be cystoscopy, removing the calculi, or removing whatever obstruction that may be causing the problem. Urethritis is the inflammation of the urethra, causing symptoms similar to the other UTIs. It is most common in postmenopausal women and appears to be caused by tissue changes related to low estrogen levels. For men, the most common cause are STDs like gonorrhea. Let's change gears and talk about non-infectious disorders. In the comic strip on the right, the doctor says, "The good news is that I don't think it's contagious." Some non-infectious disorders we'll discuss include urethral strictures, urinary incontinence, and urolithiasis. In this chapter, urinary incontinence is our double-starred disorder. A urethral stricture is a narrowing of the urethra. Go ahead and look at the picture. Where does narrowing occur? The most common symptom is obstruction of urine flow. So with that narrowing, the urine just doesn't flow, hence the stricture. Surgical treatment include dilation of the urethra, placing a stent, or performing a urethroplasty, which removes the problem area with an option of graft placement. Let's talk about incontinence, everyone's favorite topic. Continence is the control over the time and place of urination and is unique to humans and some domestic animals. So we can control when we go to the bathroom. So we can stay in class for an hour and know that our break is coming up and we can control ourselves. It is a learned behavior in which a person can suppress the urge to urinate until a socially appropriate location is available. Continence occurs when pressure in the urethra is greater than pressure in the bladder. So when the bladder is getting kind of full, it'll start contracting a bit. But when we're sitting in class and we don't want to go to the bathroom, we can exert some pressure on the urethra so that we don't pee in our pants. Remember, continence occurs when pressure in the urethra is greater than pressure in the bladder. For normal voiding to occur, the urethra must relax and the bladder must contract with enough pressure and duration to empty completely. Voiding should occur in a smooth and coordinated manner under a person's conscious control. That is the ideal situation. Incontinence is an involuntary loss of urine severe enough to cause social or hygienic problems. It is not a normal consequence of aging or childbirth and often is a stigmatizing and an underreported health problem. Many people suffer in silence, are socially isolated, and may be unaware that treatment is available. In addition, the cost of incontinence can be enormous. Let's continue. Incontinence has several possible causes and can be either temporary or chronic. Temporary causes usually do not involve a disorder of the urinary tract. The most common forms of adult urinary continence are stress incontinence, urge incontinence, overflow incontinence, mixed incontinence, and lastly, functional incontinence. Yep, I know it's a little bit blurry, but it's a great picture. A little overview. The bladder on the left is experiencing stress incontinence. There's too little tone, so there's a leakage. For urge incontinence, there's too much activity. The bladder is contracting and it's causing problems. How about for mixed incontinence? There's a mixture of both problems. There's too little tone in the bladder, and also there's contraction happening, so the patient is leaking. Overflow incontinence is when the bladder gets so full and then it starts leaking. We'll talk about each one in turn. First, stress incontinence occurs during activities that increase abdominal and detrusor pressure, like exercise, coughing, or sneezing. Interventions may include drugs like estrogen or teaching the client to do pelvic floor exercises, also known as Kegel exercises. Kegel exercises are made to strengthen the pelvic floor muscles. It's where the client squeezes the muscles and holds it for 5 seconds and then releases it for 5 seconds for a number of repetitions. They are used to treat urinary incontinence or to prepare for or recover from childbirth. Urge incontinence is when the client has a perception of an urgent need to urinate as a result of bladder contractions, regardless of volume of urine in the bladder. So if there's a little bit of urine or a lot of urine, the bladder is overactive. It's contracting more than it really should. So the client feels that they need to go to the potty all the time. Interventions include avoiding diuretics, nicotine, caffeine, and alcohol. Those all increase the bladder contraction. Here are a few more types of incontinence. Overflow incontinence is when the detrusor muscles don't contract, and then the bladder is over-distended. So it's so full, and it's just going to leak when it's so full. Mixed incontinence is a combo of stress, urge, and overflow incontinence. Functional incontinence is when there's a leakage of urine caused by factors other than the disease of the lower urinary tract. Let's take a look at your handout. Take a look at chart 69.9. It talks about bladder training and habit training to reduce urinary incontinence. When you get a chance, go ahead and cut and paste this address and you'll watch a great little 2-minute video on bladder training. Now, what's the difference between bladder training and habit training? Bladder training involves education for clients. The client must be alert, aware, and able to resist the urge to urinate. This is different from habit training because habit training is a type of bladder training that is successful in helping cognitively impaired clients. Also, look at chart 6910 so that we can learn how to teach our clients to self-manage their urinary incontinence. Next topic, kidney stones, urolithiasis. Do you see the stones in the ureter, bladder, and kidney? Urolithiasis is the presence of calculi in the urinary tract. Calculi often don't cause symptoms until they pass into the urinary tract. Ouch. All right, on to urolithiasis pathophysiology. Stones are caused by many disorders. However, the exact mechanism of stone formation is not entirely understood. Everyone excretes crystals in the urine at some time, but fewer than 10% of people form stones. Most stones contain calcium as one part of the stone complex. The formation of stones involve 3 conditions. Slow urine flow resulting in supersaturation of the urine with a particular element like calcium that first becomes crystallized and later becomes the stone. So if there's a stricture in the urethra, or maybe the nurse doesn't take her break and go to the bathroom, or maybe a kid wants to go play his video game and doesn't want to pee out all his pee completely, there may be a slow urine flow and the urine hangs out in the bladder longer than it should, and then the urine hangs out with the calcium longer than it should. That may cause some crystallization, and can lead to a stone. The second condition includes damage to the lining of the urinary tract. And the third is decreased amounts of inhibitor substances in the urine that would otherwise prevent supersaturation and crystal aggregation. Our body is amazing. There are things that cause stones, but our body has ways to inhibit stones as well. But when you don't have enough of that inhibitor substance, stones form. When we do an assessment, we're going to ask about personal or family history, any severe pain, also known as renal colic for urolithiasis. How about their urination? What's the frequency like? Is there any pain? Is there just a little bit of urine or no urine at all? How about any bladder distension? Do you notice anything? How about the vital signs? The vital signs may be moderately elevated due to pain and/or infection. The blood pressure may be decreased if the severe pain causes shock. More on assessment. For urine analysis, hematuria is common due to stone-induced trauma, so there may be some blood in the UA. You may notice elevated WBCs due to urinary stasis and infection. There may be bacteria due to the urinary stasis. And there may be increased turbidity due to infection and sediments. Blood work-wise, you may see an elevated WBC and elevated mineral counts. X-rays, IV urograms, CT, IV urography, and renal ultrasonography all can help identify stones. Let's talk about ways to manage pain for our clients who have urolithiasis. For drug therapy, the client may need opioid analgesics like morphine, or maybe just NSAIDs would do, like ketorolac. You may want to try complementary and alternative therapy, which includes things like relaxation, acupuncture, and guided imagery. Lithotripsy is when sound, laser, or dry shock waves are used to break up the stone into small fragments, and then the client can hopefully pee out those small fragments. If all of those interventions don't work, surgery may be needed. Minimally invasive surgical and open surgical procedures are used if urinary obstruction occurs or if the stone is too large to be passed. When other stone removal attempts have failed or when risks for a lasting injury to the ureter or kidney is possible, an open ureterolithotomy or a pyelolithotomy or a nephrolithotomy procedure may be performed. These procedures are used for a large or impacted stone. More interventions. So we want to prevent infections from happening. So we're going to use antibiotics. We're going to give proper nutrition, give adequate fluids. We're going to prevent further obstructions using adequate fluids, drugs, and encouraging our client to walk because that helps to pass the stones more quickly. So go ahead and take a look, chart 6911, for self-management. Urolithiasis. Now let's take a look at the chart on the right. For your very last P, now be honest, were you at 1, 2, 3, or 4, 5, 6, 7, and 8? What color was your P? So if you were 1, 2, or 3, you were properly hydrated. Continue to consume fluids at the recommended amounts. Way to go! Now, If your urine color is below the red line, you are dehydrated and are at risk for cramping and other health illnesses. You need to drink more water. Now, let's talk. Why is it important to drink 3 liters or more a day? Why do you want urine in the 1, 2, or 3 category? Well, let me tell you. Diluted urine helps to prevent dehydration, promote the flow of urine, and it also, this is the big one, decreases the chance of crystals forming a stone. So 1, 2, 3, those are our magic numbers. 1, 2, 3. Oh, we're done. All right, well, enjoy these quotes, and I'll see you in class.